So good morning. So seeing as CLEX seems to be the new way to go in refractive surgery, I thought I'll talk more about the procedure in itself. So we have at our place the Zima. So it's a mobile surgeon controlled unit. It's got a very easy to use patient interface and it offers very reasonable post-operative outcomes. So Zima call it corneal lenticular extraction for advanced refractive correction. We call it CLEAR. Now, the procedure itself is quite simple. It's very close to the other CLEX procedures. So what the company recommends is that you mark the axis 90 and 180 like you would for a toric. You can also use the Avad marker, which is available commercially. We prefer this because we haven't got the marker yet. Then the handpiece. Now, it's a handheld handpiece, unlike the gantry operated ones that you have in the Smile and in the Ethos or in the Elita. So it allows you to either single dock or double dock. The double dock is a very easy option because it allows you to put the vacuum ring on top of the eye without too much patient movement, and it's very helpful in deep set eyes as well. You can also single dock. You can just hold the handpiece directly over the patient if you have a patient who's very cooperative. Both work equally well. Once the handpiece is docked, the machine then starts to apply vacuum. That takes around 5 to 7 seconds. You'll see that once the vacuum has been applied, the pupil tracker will engage. You'll see the ring around the pupil. And once that's done, the OCT will start. The OCT, you can then adjust the depth of resection wherever you want it to be. And then once that's sorted, you can even check to make sure your incisions are right, and then you can start resecting. So resection is the same. The posterior cap goes first, the anterior cap is second, then you have the incisions, and then you have the venting tunnel. This entire process takes around 13 to 16 seconds on average, depending upon the power that you're correcting. The incisions are customizable. You can make one, you can make two. You can even make the incisions one into the anterior cap and one into the posterior cap, but all this is done in the planning stage. Now, when you're starting to dissect, it's a little different than what you do with Smile. You first have to find your planes. So basically, we use the spoke, which is a very small instrument. We pass it into the cap. This is the anterior cap. You'll find that it has more resistance. And then you'll pass it into the posterior cap. It's a lot smoother. You try to overlap these two grooves. And then if there's no resistance, it means you're there in the same plane. You're just dissecting the same plane over and over again. If there is resistance, it means that you found the anterior and the posterior planes. The next step is the dissection. Now, this being a biconvex lenticule, it doesn't matter. You can dissect either the anterior or the posterior cap first. The anterior cap takes a little longer because the stroma is a lot stickier. As you can notice here, the dissection is a little harder than the posterior cap. Once you finish the anterior dissection, you needn't have to actually cut the side walls. You just have to be sure to dissect the central part. You then move into the posterior cap, where you see the dissection is a lot smoother and a lot faster. As you're finishing about 50 to 60% of the dissection, you will notice the lenticule start to fold over on itself. You'll see that bulge on the corner. That means that the lenticule has now separated. So then you move on to the extraction. So it's preferable to ask the patient to look down a little. This makes it a little easier. You then use the forceps to gently peel the lenticule out. Now the next step that we do here is the most important part. We check to make sure the lenticule has come out in its entirety. So you put a little drop of saline and you can use the forceps to gently smoothen it out. Make sure it's completely round and that you have no remnants left behind. The proprietary algorithm in the Zima makes sure that it's very hard for you to have a remnant lenticule left behind. Now, this is a bit of a controversial step, the pocket irrigation. Some people do it, some people choose not to do it. We do it. We put in a little aliquot of saline and then we gently brush and, brush the stroma from side to side, and then we use a Weck cell to smoothen it out and dry up the incision. Now, there are some people who say that overhydrating the pocket can cause stromal hydration and delays visual recovery on postoperative day 1. But then I have colleagues in the Middle East who actually put in dexamethasone or diluted triamcinolone to reduce the interface inflammation. So then again, this is a bit controversial, to each their own. Now, it's not you do have problems. The most common problems that we have with clear is that you have smaller incisions. So if you have a patient who's moving around too much, or if you have a patient who's constantly uprolling, you'll notice that the incision is being torqued by the instrument. And what will happen when you finish your dissection is that you will be left with an incisional tear. This does heal, but it does cause significant postoperative discomfort. This is a black spot. This is where the laser has not cut the cap. You see the area there where there's no bubble, no cavitation bubbles. So what will happen is when you try to dissect that part of the lenticule, you will have a bit of struggle because the lenticule has not been dissected completely. Because it's biconvex, you can dissect posterior and then come back up and dissect this part again. It'll just take a little while, and the patient will have a little bit of postoperative inflammation that will delay his or her recovery. You can have an adherent lenticule, especially in the periphery. So you may have to be gentle. So it's like tearing the check leaf out of a checkbook. You'll have to go and tear it off little by little from the periphery, and you can get it out in one go. Again, check to make sure that you've removed the lenticule in its entirety and that you've not left any remnants behind. Lastly, like I discussed earlier, the stromal hydration. If you hydrate, you'll notice the corneal stroma becoming hazy, and this will actually carry forward onto postoperative day 1. So yeah, just hydrate gently. Apart from this, the most common problem that we have in clear or any form of CLEX is the postoperative day 1 subconjunctival hemorrhage that you'll have to sit and explain to your patients. You can have uncommon problems as well. These are not seen very rarely. In fact, I've not had most of them. Intraoperatively, you can have an opaque bubble layer. You can have a cap tear. You can have an incisional tear like I showed you earlier. You can even have a cap perforation where your instrument can poke through from anterior and go posterior, or vice versa. You can have traumatic epithelial defects which cause significant problems postoperatively, and you can have a decentered ablation. However, that can be controlled using the cyclotorsion and the pupil centration correction. Postoperatively, we rarely see it, but you can have lamellar keratitis. We have had few cases of pressure-induced stromal keratitis, which were treated with reducing the steroids and adding anti-glaucoma medications. Residual errors, recurrent corneal erosions, interface infections. Higher order aberrations are very, very common. Patients do have glare and halos, especially in the first 1 month. We actually counsel them for it. Night driving sometimes becomes an issue, especially when you're correcting astigmatic errors. Ectasia regression, of course, has been described. Now, the disadvantages are pretty much the same as with any other CLEX procedure. You have limited power correction, especially when it comes to higher astigmatism and hyperopia. Like I mentioned earlier, the higher order aberrations, glare and halos do exist. You do have to tell the patient because it will delay his or her recovery time. And there is a little problem with neuroadaptation bilaterally, especially for patients who undergo any form of keratorefractive lenticule exchange procedure. But the clear is a surgeon controlled mobile unit. It offers cyclotorsion and pupil centration, manual of course, unlike the Smile Pro which is automated. It's mobile, and therefore it really helps when you're trying to reduce your cost per unit in terms of operations. And with that, I'll conclude. Thank you so much for your patient listening.